Hello everyone, my name is Lenny Coppens. I'm a PhD student at the University of Antwerp in Belgium. First off, I would like to thank the organizers for selecting my abstract, and I apologize for not being able to present this work in person. Nevertheless, I'm very happy to share with you my research today, where I will look into the role of persistent free spike antigenemia after SARS-CoV-2 infection and its association with long COVID or post-COVID condition, as we call them. First of all, authors have declared that there is no conflict of interest, and this project has received funding from the European Union's Horizon 2020 Research and Innovation Program under the Orchestra project. Quick introduction on the Orchestra project. Orchestra was a 4-year international research project with more than 300,000 participants, mainly across Europe. And it aimed at tackling the coronavirus pandemic, particularly looking into immunocompromised patients. After the big pandemic, the focus shifted towards post-COVID condition, PCC. If you look at the pathobiology of PCC, spike antigenemia has been proposed as a potential contributing mechanism. And there's also spike antigenemia has been proposed as a potential biomarker. Indeed, if you look into literature, there are studies that show a positive association between spike antigens and antigenemia and the development of PCC. However, we also find studies that contradict this. We thus think there is still room for additional independent studies to clarify this link. An important side note is that most of the studies that show a positive association between antigenemia and PCC have used a compound DDT, which is a reducing compound which reduces disulfide bonds, with the aim of leaching out bound S or N antigens from their cognate antibodies, thereby facilitating the detection of a total antigen pool. Since we had within the Orchestra consortium the availability of longitudinal follow-up samples, we also aimed at looking at the role of spike antigenemia in PCC. So to do this, our study had two main objectives. Firstly, to also evaluate the effect of this DDT on spike detection in our setup. And secondly, to look at the dynamics of S and N antigenemia in the post-acute COVID-19 phase and its correlation with PCC development. To do this, we looked, of course, we measured S and N antigens, we measured pro-inflammatory cytokines and IgGs using the mesoscale discovery setup. Our study cohort consisted of 112 patients who developed PCC, 58 patients who did not develop PCC, and 18 pre-pandemic controls. We had samples from various time points, acute time points, 3 months, 6 months, 12 months, and 18 months after acute infection. Why is it important to look at the effect of DDT on spike detection? Well, if you look at the structure of spike of the RBD region, it has been shown that there are several disulfide bonds, which are indicated with the arrows, within the RBD region, and which are known to be essential for the functionality. Thus, our initial concern was that by treating these samples with DDT, you might also be reducing the disulfide bonds in the RBD region, thereby causing a hurdle in antibody-based detection systems, since the integrity of the protein is compromised. Well, to evaluate this, we did a first experiment in which we treated recombinant spike proteins with various amounts of DDT, and we observed a clear dose-dependent reduction in spike signal. Even at 10 millimolars, which is a concentration often used in other spike antigenemia research, we observed a 91% reduction in signal. Of course, this is in an aqueous artificial matrix, and therefore we, in the next assay, spiked pre-pandemic plasma with this recombinant spike protein, and also treated those samples with 10 millimolar. Only with the 10 millimolar concentration, as we think this is relative to the previous studies, and we also had a limited amount of samples and spots on our plates. But nevertheless, we see a similar effect. We see a significant decrease in signal, meaning that in our setup, DDT is compromising the detectability of spike protein. We were a bit puzzled because we did see actually an increase in signal upon treatment with 10 millimolars of DDT, except for this one patient, which had very high levels and upon DDT treatment decreased significantly. This was puzzling to us, so the next step, what we did was to treat pre-pandemic plasma samples with DDT, and if we don't treat these samples with DDT, they all are undetectable, but surprisingly, upon this treatment, the signal increased significantly. And this is worrying because we know that there is no spike present in this pre-pandemic plasma, and it suggests that DDT is generating neoepitopes, which of course is artifactual and not reliable. So based on these previous findings, we discontinued the use of DDT in the investigation of the temporal dynamics of antigenemia. So we only looked at the free fraction of antigens. First, most importantly, our pre-pandemic plasma samples are still negative for both S and N antigenemia, and thereby confirming our assay specificity. If we then look at the acute phase for N antigenemia, almost all cases are detectable and they reach quite high, 10 to the 6th femtograms per ml, while in S antigenemia the frequency is a bit lower, although there are still patients with very high levels. If you look at the post-acute infection time points, we see a steep decline in levels, but nonetheless, they are still detectable, however, at very low concentrations, but still detectable all the way up to month 18 for both spike and antigenemia. And it also appears that there is not really a difference between patients who have PCC or those who did not have PCC. Well, to confirm this, we did some additional statistical testing. We used a multivariate mixed effect model that controls for age, gender, time point, and repeated measurements, but also here there was no significant association between PCC in general and any of these antigens. We further stratified PCC into symptom clusters based on the clustering provided by our colleagues within Orchestra, Gentilotti, which is also published in Lancet, but also here we didn't see any association between the antigens or any of these symptom clusters. Nonetheless, we did see that in some individuals there is low residual amount of spike proteins, and we wondered that there might be intra-patient patterns that we are not observing when we do this global analysis. So for that, we looked into, or we performed a correlation between spike antigens, inflammatory cytokines, and serology measurements. We subsetted the data, which revealed a distinct pattern showing that spike antigens are actually mainly during at month 6 and month 3 and month 6 are mainly positive, correlating. It shows a positive pattern with inflammatory cytokines such as IL-6, IL-1 beta, mainly in the PCC group, and this is absent actually in a non-PCC group, meaning that are indicating a more resolved immune response over the time for the non-PCC group. So actually, to conclude, we see persistent spike and nucleocapsid antigenemia only in a small number of PCC, but also non-PCC individuals, but up to 18 months. We do show that there is no association between antigen levels and PCC or any of its symptom clusters. but that these low levels of spikes do correlate with several pro-inflammatory markers in the PCC group and not in the control groups. And lastly, quite important, that DDT denatures spike, at least in our assay, and induces artifactual neoepitopes in pre-biodemic plasma, suggesting that use of DDT should be approached with caution in spike antigenemia studies. Lastly, I would like to thank my supervisors and all participating members within the orchestra project that made this study possible. And I would like to thank you for listening and attending this presentation. And I'm happy to take any questions.